Welcome to Gracefully Graying. I am your host, Attorney Henry Gornbein. Today on Gracefully Graying, I am pleased to welcome as my guest Geoffrey Hoffman, who is an assistant professor with the University of Michigan School of Nursing, as we discuss falls and other aging issues. Jeff, welcome to Gracefully Graying.
Thank you so much, Henry. Pleasure to be here.
Tell us about your background.
Sure. I have a degree, a doctorate in public health, essentially health policy and management. I study aging, the science of aging, and specifically how the healthcare system interfaces with the care of older adults and outcomes, health outcomes. So I've spent a lot of time learning to academic research and methodology, also learning content matter about the science of aging. And I also had the opportunity to spend some time in Washington burnishing my policy chops. After I got my master's degree in public health, I went out there and I actually worked for Congress for a while during the drafting of the Affordable Care Act. So I sort of have a cross-pollination of background in the science and the policy aspects of the healthcare system and health.
Tell us about your current position with the University of Michigan School of Nursing.
After I got my PhD from UCLA School of Public Health, I came out to Michigan and I did a postdoctorate degree at the University of Michigan School of Nursing. And then I converted over to an assistant professor tenure track position where I currently still have that position. I teach PhD students how to do statistics and econometric modeling, research methods, and I write papers and work with colleagues and mentor PhD and master's students.
I'm curious, when you talk about public health, we're in the middle of COVID, of course, and public health is a huge issue. Are you involved in any of that?
I am. Like all of us, I'm on, interestingly, the receiving end of a tremendous public health experience that we're all going through, seeing family members going through it and trying to manage it. In terms of being on the research side of it, the University of Michigan has a lot of academics who've engaged with new studies COVID, whether the science of it or the public health infrastructure surrounding our response or lack of response to it. I've done a little bit of work on that end. To the extent I've been involved and changed the trajectory of my research under COVID, it's been thinking through the long-term effects of COVID on sedentary behaviors, physical activity levels, and functional status for older adults, as well as the healthcare system, the long-term services and support system, and how it can help older adults respond to COVID and the threats to health. So I wrote a paper that was in the Journal of Aging and Social Policy as part of a series on COVID with like 25 papers from leading long-term care experts. I wrote a paper that was thinking through a new framework for supporting older adults under COVID or post-COVID. I think one of my big concerns because of COVID is that we have what I imagine to be a sort of perfect storm where
yes, we do.
Physical function, I study falls, and so I see, for better or worse, a lot of things through the lens of falls and function. I study falls because I think it's sort of a primary experience as we age. It's an indicator, if you will, of declining function, declining ability, and it can lead to or segue into loss of independence, which I think is a really devastating thing for any of us to experience. And so as sort of the sentinel, indicator of loss of function, a fall is such a critical thing. And my worry is that under COVID, people will get out less, they will do less activity, they will lose function, and we could have sort of an epidemic of falls. Added to that, additional risk factors for that people have gone into the healthcare system less because of fears of contracting COVID for obvious, for reasonable reasons. People who've been hospitalized come out and are getting less access to post-acute rehabilitation. And then caregivers are less able to go into people's homes, older individuals' homes, to help them. So my fear when it comes to COVID is how well we're going to be able to support older adults. If I'm right that there may be an epidemic of fall risk. And I think when you add to that there are all these budgetary concerns, if state governments and municipalities aren't going to have the resources to fund a lot of the programs that help older adults, I think that generates what I think of as this terrible perfect storm that we might all have for now.
Jeff, let's talk about falls and how large an issue is that as we're aging? And, you always hear about the fact that someone's doing fine. They might be in their mid-80s, they might be younger, sometimes older. They take a fall, something breaks because as we age, we're more and more, our bones lack density, for lack of a better word. And then everything goes downhill, and before you know it, someone's gone. Let's talk about that.
Yeah. Falls are a common experience as we age. It's a question of when for most of us. Every year, about a third of older adults, here defining older adults as 65 years or older, every year a third experience a fall. This would be among older individuals living within the community. And of those falls that occur, a third again of those entail injury that requires medical care. So put simply, a third of older adults living in their own home, not in a nursing home, fall each year, and about 10% of older adults living in the community have a fall-related injury each year. And fall-related injuries, as you say, can often lead to debilitating consequences. So they can be mild or moderate. They can just be a sprain or a contusion. You just get a black and blue mark or something like that. But if you get a break of certain body parts, if you get a hip fracture, if you get a skull fracture, you fall down backwards and hit your head, it can lead to urgent care and institutionalization. So falls are the leading cause of institutionalization for older adults. We have scary statistics out there. I don't want to scare anyone. I don't think there's anything to be scared of, but it's worth knowing that after things like hip fracture, life expectancy is not, is expected to be around a year. That's just an average. That doesn't mean it happens to everyone. Having said that, falls don't need to be a scary thing. Falls can also be a marker of people are just being a little more active and they trip and slip because their balances and proprioception or sense of space isn't as good as it once was. Vision and hearing aren't there. They trip on a crack in the sidewalk. You can have no falls if you never get out of the house too. So my message when I talk about falls is always, let's remember that to have a fall, you need the opportunity to have a fall as well as your health and your underlying risks for a fall. So if you never leave the house and never have a fall, that's maybe not the best thing ever either, if that makes sense.
Well, there's certain things to me, exercise is important at any age. And I also have heard that, I know there are classes where you learn how to fall. It's like you go into a tuck position if you can, but often when you're falling, it happens fast and you don't think, you just kind of plop. So
that's right. I mean, the good news about falls is that we know that prevention can work. And so I take your point that when it's occurring, it seems a little too late at that point to think through ahead of time. Well, gosh, what should I do? Even for middle-aged and younger adults, the response, the ability to transition from one leg to the other and switch your center of mass and do all these things that you do that can help prevent actually going down and hitting the ground, or if you do hit the ground, to cushion the impact. Those are easier when you're younger, you're more pliable and flexible, et cetera. Having said that, prevention does and can work. We've done a lot of clinical trials of prevention activities, whether it's just improving flexibility through Tai Chi classes, or working on muscle and strength and gait, that really do make a difference. It can also be clearing your house of obstacles. And I think it's a little like, the sports metaphor, like, I'm a UCLA alma mater, and John Wooden, the famous coach there, always used to say that you play and you win the games before the game ever starts. So like practice is sort of the key. If you wait till the game to sort of make in-game adjustments, it might be too late. So to your point, like if you're waiting till the fall happens, yeah, it's going to happen too fast to sort of make a difference. But maintaining your gait and flexibility, doing some muscle strengthening exercises, these things can help when that moment comes to sort of be more ready for it, or to prevent the fall from happening, if that makes sense. So that's the good news about falls. The bad news is that as public health professionals, we haven't done the best job of delivering these programs, these prevention activities, interventions, and information to older adults, unfortunately. I think part of that is because there's a stigma around falls and they're uncomfortable to talk about. And the other problem is the Medicare program doesn't necessarily pay for these prevention programs. So, it gets a little messy.
So what is the information you should be delivering? I mean, here's a form. We reach locally, we're reaching nationally. What is some advice that you would give to those of us who are aging gracefully, on falls, first of all, about prevention, and also about dealing with them if they happen? I mean, there are ways to lessen the impact. Tell us.
It's a great question. So let me see if I can sort of consolidate around a few ideas. The first is, and these are going to sound sort of very basic, and people are going to be like, "Well, no, duh, of course," but I'll just lay them out there. Stay active. My fear is that the fear of falling is, I don't want to say almost as risky as the actual risk, as the dangers of a fall, but fear of falling can prevent people from getting out and doing stuff. So trying to work on avoiding being sedentary is really critical as we age, to try to stay busy and active, get out of the house. Even things as simple as self-isolating in the home can lead to sort of loss of function in the same way that having an injury can. So staying active would be the first thing. The second thing would be you've got to work with your clinician or pharmacist to make sure that the prescription medications you're taking are appropriately dosed. So we know that there are strong links between some prescription medications and falls. So sort of loss of balance, dizziness, things like that, especially if you're using multi-pharmacy, a bunch of different drugs at the same time. As we age, we need to make sure that we're getting what we need pharmaceutically, but tailored in a way that we're not unnecessarily risking falls. So that's the second really critical thing. The third would be an environmental approach, is thinking through risk factors in the home. These things sound so silly and petty, but even in my own home, I'm a new father and I'm carrying my little baby around and I'm exhausted. And if I've left stuff on the floor, it's just so easy to absentmindedly trip over something. So doing simple checks around the house about, do you have proper lighting, or do you have lights out? Do you have guardrails, handrails on the stairs? Do you have a grab bar if you need one in the bathroom? Do you have slip mats in the shower? Do you have clutters on the floor? Things like that. So staying active, one; pharmaceutical and pharmacy stuff, two; environmental safety risks, three; and then the fourth are what we call the intrinsic risks, things within ourselves that could lead to risk. Do you have vision issues that need correcting? Do you need corrective lenses? Hearing can be an important thing because people sometimes, as we age, our executive processing deteriorates a little, and that means our ability to sort of do two things at once, so process information as we're moving down the sidewalk and have a conversation, get a little more challenging. As a new dad, I'm already having these issues, I'm finding. So, if you need a hearing aid, something like that. And then just the things we talked about. I mean, it just seems to be the case that muscle strength, gait issues. So if you're having trouble sort of because of arthritis or something else of lifting one leg the appropriate height to sort of get it over into the step through to planting it as you then lift your other leg up. If you have problems with these things, it is worth, even if it feels frustrating, going in to see a physical therapist or an occupational therapist. Trying to stay on top of those sorts of issues, and then muscle flexibility, doing things like Tai Chi or yoga can be really helpful. I know that can sound like, oh, I don't want to put time into those things, but they can help. So those are 4 areas that I think are really critical. Interestingly enough, just walking has not been shown to prevent falls. I would not use that information to say don't walk. I think walking's the most excellent exercise there is, but just walking itself without doing some of the muscle strengthening exercises and flexibility training hasn't been shown by itself to reduce falls. So I think those are the four critical areas. And I would just add to that, there are some wonderful documents that the Centers for Disease Control and Prevention, the CDC, has put out. They're called the STEADI brochures, STEADI. And they have information about how to find clutter in your house and declutter, and how to assess your risk for falls and things like that. I'll just add a 5th and last one, and test your patience here with a long answer is...
No, but this is important. It really is, Jeff. And what's interesting, I personally do a lot of physical activity. I do an elliptical several days a week. I also do weight training 2 or 3 times a week. And what you're saying, walking is important, but you need to do weight training, exercise those muscles. So I think that's important.
That's exactly right. And let me just quickly tack on one last thing.
Sure.
So everything you're doing is great, and I would encourage others, if they have the time to be able to do some similar things. And there are within local communities at senior centers and elsewhere access to programs. If you don't have weight equipment at the house, you can have fall prevention classes that take place at senior centers and in certain communities. So there are places to get some of this training with help from others, Tai Chi classes as well. But the 5th thing I would say is, and this is in some of my recent work, fall risk really spikes right around a hospitalization. So the other critical time to think about falls is when you're not doing well elsewhere. So if you find yourself into the hospital, either because of a fall or because of some other condition, whether it's heart related or respiratory related or whatever, it just seems to be the case that falls sort of spike at the same time that these other sort of acute conditions arise. And what that means is when you're in the hospital, you have this underlying health risk that brought you in, but your fall risk spikes at the same time. And that means when you leave the hospital, you're also leaving with really heightened fall risk. So we see this sort of 2-pronged risk around a hospitalization with falls, where it spikes in the week or 2 before, and it spikes in the week or 2 or 3 after. And if we're not careful there, we go home, we're trying to rehab from whatever brought us into the hospital, but then suddenly we have a fall. So everything that you and I have been talking about and the sort of 4 areas of risk, the time to really pay attention to those is when you're having other health issues, just for whatever reason. We're not sure why, but that's really important.
Things happen. I have a friend who always used to say that life is like a minefield. Something's going to happen. It's just a matter of where or when. So let's get to the economic impact, because, what happens? You fall, something breaks, or you may have a head injury, because often it's a fall so you're hospitalized. You may have to be taken in an ambulance. So there's got to be a tremendous economic toll as well.
Yeah, you're absolutely right, Henry. We've done some modeling of this. Actually, my dissertation work focused exactly on this question. The Medicare program, as we know, pays for the large portion of acute care expenditures in this country, of acute healthcare in this country. Estimates vary. It's a little hard to nail down exactly what we're spending on falls, and for technical reasons, I won't bore your audience with why it's hard to nail down the cost. But the work that I've done suggests that Medicare spends anywhere from $10 to $15 billion a year. This was in 2008 dollars, so let's say $20 to $30 billion a year on fall-related injury. So injuries like fractures, contusions, sprains, et cetera. And others have found slightly higher annual expenditures, 40, 50 billion. I think the estimates from another team are we're going to be spending $40 to $50 billion by 2040. We know we have a massively, rapidly growing aging population. And the growth is greatest in the oldest old, 80 and older. And so that's where fall risk is greatest. So we expect these numbers to continue to increase over time. Another thing that's driving spending on fall injury in the US is possibly a good thing. The conundrum of falls I brought up before, which is people are staying active more longer and living longer. So there are more opportunities for falls when you're more active. So we know this generation of older adults, baby boomers, my parents' generation, they're living much longer than earlier cohorts of older adults, and they're more active. And so we should expect to continue to see lots of spending on falls. We also modeled the costs of falls in treated in emergency departments, hospitals, outpatient ones. They range from anywhere from like $7,000 per fall injury to about $20,000. They're pricey. If you put the numbers I've given you in context, the total spending each year on fall-related injury, I think this paper was from a while ago, but I think we said it's on the order of what we spend on diabetes, or in the ballpark. So it's really big. Another paper I recently did showed that, hospital readmissions have really been in the news. Fall-related injuries are the third leading cause of hospital readmissions, meaning if you leave the hospital for whatever, you were hospitalized for a heart attack or, respiratory failure or something else, complication of diabetes. If you come back within 30 days, the third leading diagnosis is a fall-related injury. So falls are just like a primary component of our healthcare utilization and spending. It is the bottom line. What's fascinating to me and why I'm so interested in falls from an economic standpoint is, one would think because Medicare has such a burden in terms of the cost, how much this costs every year, that we would put more into prevention of fall injury. But Medicare, by statute, doesn't typically pay for prevention. It pays for treatment once an injury has already occurred. And that's a conundrum that's a little bit
we got to change that. I mean, we got to emphasize more on prevention, which is, I guess, we fail in many respects. What about the cost of rehab? That's got to be a huge cost as well.
Yeah, rehab costs are very expensive. We know for years now that the critical drivers of spending and inflation in Medicare spending has been in post-acute care. To define post-acute care for the audience, there are different categories, but you have, when you're discharged from the hospital, they can discharge you home to the community, or they can refer you to a skilled nursing facility or a nursing home where you can be for a short time to rehab, or you can stay a longer period of time if you need more time there. You can also get referred home discharged home with a home health care referral, meaning a home health aide will come to the home and help you with tasks until you're able to get back on your feet. There are also different, in addition to a nursing facility, you can go to an inpatient rehab or an outpatient rehab facility where you do more intensive rehab. Because these costs have been so expensive in the past 10 years or so, Medicare has paid more attention to that component of spending, not just for falls, but elsewhere. And so they've introduced, I'm not sure if your audience is familiar, that Medicare's introduced new programs to try to reduce spending. And those involve things like bundled care payments, Bundled Payment Care Initiative, the Bundled Payment Care Initiative, BPCI, which basically gives a lump sum payment to providers, both the hospitals and post-acute care providers. It's up to those providers to manage care to keep costs below the payment that Medicare has provided. So rather than the typical Medicare payment where the user, the older individual, the beneficiary, moves through the healthcare system and Medicare reimburses each unit of care that they use, instead Medicare pays up front, we're just going to pay you this amount for however many units of care you use, and it's up to the providers to restrict those units of care. What's happened under this initiative, sorry if that was a bit overly complex, I can break it down, but what's happened with that is we've really restrained post-acute spending. And so what the concern is for researchers like myself who care about gerontology is what's going to happen to falls, what's going to happen to function if you start restricting access to rehab.
It's like a perfect storm in many respects. And we've just got about 2 minutes, believe it or not. And Jeff, are there any other injuries that we should be concerned about as we're aging? And
I mean, you know, there probably are. I'm hyper focused on falls, and so that's the one that I've spent the most time thinking about. I mean, certainly as we age, you know, in the context, falls are the #1 injury when it comes to what puts older adults into the emergency department in the hospital and to become institutionalized. So that's, I think, the interest in focus on falls. They're also preventable, as I say, and also cost a lot of money. So it's a sweet spot for the healthcare system to focus on. I certainly think other areas like car accidents, thinking through, you know, at what point should I maybe stop driving or make sure to get regular checkups of vision and hearing so that I'm driving safely. You know, those are other thoughts that merit consideration. But just sort of reworking the injury focus, you know, I think what I'm interested in doing is shifting the focus from injury to independence. When we just talk about injuries, I think all of us have a gut reaction of, I'm fine, I can manage it, or yeah, I tripped, I had a little stumble, but I'm not really at risk of injury. But what all of us truly are interested in and interested in talking about as we age is our independence and autonomy. And so I would just urge listeners to think through, you know, when we talk about injury, we're not trying to say, be careful, be so safe that life's no longer enjoyable. We're trying to say, how can we best manage an independent, graceful graying process like you guys talk about? And one of those ways is to stay flexible, to do all those checks, those 4 points, 5 points that I made.
what about yoga and Pilates? Important? What do you think for flexibility and staying healthy?
If you ask my wife, absolutely. She's tried to get me to do Pilates. I'm a little intimidated, but yoga, absolutely. And Pilates too. These are wonderful things to do. Absolutely. Anything that improves core strength is really where it's at.
Jeff, we're out of time. Geoff Hoffman, I want to thank you so much for being my guest on Gracefully Graying. I want to have you back to continue this discussion because there are so many issues that we face as we're gracefully graying and aging. I want to have our viewers remind us to look at our Gracefully Graying YouTube channel and also visit and like our website at gracefullygraying.com. And I want to thank our viewers for watching. Jeff, it's a pleasure having you. Thank you again.
Thank you, Henry. Pleasure being here.